Good evening, everyone, and thank you for attending AACP's webinar on New Age in Geriatric Dentistry. Dr. Skaggs has no conflicts of interest. I would like to briefly mention some upcoming events. First, our friends at ACAM are hosting a COVID update webinar on February 3rd. Also, don't forget to register for the Medical CBD course for healthcare professionals with Dr. Gregory Smith on April 16th. Lastly, AACP is hosting a 2-day TMJ Fundamentals and Injection course this upcoming May. Dates will be confirmed soon. Our speaker today is Dr. Melissa Skaggs. After graduating from the University of Texas Health Science Center, San Antonio Dental School in the year 2000, Dr. Skaggs continued her education by completing a 12-month advanced education in general dentistry residency at Texas A&M College of Dentistry. She then entered private dental practice, purchasing her first office in Carrollton, Texas in 2003. She diligently took many hours of continuing education credit. By 2008, she had been awarded the prestigious master's status in the Academy of General Dentistry. Dr. Skaggs began specifically marketing to senior patients in 2014 and focused on treating this special population ever since. She has been married for 24 years and has a 9-year-old son named Wilson. And Dr. Skaggs, I'd like to hand it over to you.
Thank you, Jordan. I just wanted to say thank you for having me this evening. And, I hope that I can bring a new, help you to have a new vision of geriatric dentistry. And you heard in my introduction that I'm not a geriatric dentist, which is actually, an accredited specialty under the ADA. But I think at this day and age, we all are going to have to pitch in to treat the number of seniors that we are going to be seeing and have already started to see. So as Jordan mentioned, we're going to be talking about what I call the new age in geriatric dentistry. There has been an unbelievable explosion in the number of seniors, and we need to be ready as dentists and healthcare providers to take care of them. So first, I would just like to go over what like the generations are and what we consider a senior. So I've listed here, as you can see, the different generations, and currently anyone 65 or over is considered a senior. So you can see with the ages there that the baby boomers are moving through right now, becoming seniors. So, about half of them have already moved over the age of 65, and the other half are still on their way there. So, and then our seniors will also encompass the silent generation, which is not a generation that I knew much about before I started looking into this. And then also the greatest generation, which obviously they are much older at this point, and there aren't that many of them left anymore. I personally am a member of Generation X, so we're there. And then below us is the millennials, the Gen Z, and there's some talk about maybe merging the millennials and Gen Z together. And then there's the latest generation, which is being born right now. The discussion is if they're going to be called Generation Alpha or not. We're not really sure. And I have a feeling that where children are born in relation to the pandemic is going to kind of separate one generation from the other, whether they remember this pandemic that we're in or not. So when we're talking about seniors, our senior patients, they are going to be in those upper 3 generations that I mentioned. And you can see here the US population in these age groups. So there is still 1.3 million people of the greatest generation living in the United States. And then the silent generation there, you can see they are roughly 20 million. And then of course, the baby boomers with their such large population is about 70 million. So this is a lot of people that are moving into their senior years that we need to be ready and willing and able to take care of, not only as they're in their 60s or 70s, but all the way up into their later years. As I started studying seniors, and I did because of the population that I serve. And in my introduction, you heard that I started marketing to seniors and in about 2010. And in that year, I started becoming very interested in treating seniors, partially because I had purchased a practice that was mostly senior patients. The doctor had worked and treated his patients for 40 years, almost 40 years, and his patients had aged with him, as happens in most practices. And so when I took over his practice and he retired, there were a lot of patients that were, retirement age, meaning in their 70s or mid 70s. And now those patients are 10 years older. And as I treated these patients, I started to attract more of the patients of this age and became even more dedicated in finding the best ways to treat them. And I realized there's really not a lot out there to help us sometimes as with this population. One of the books that I've recently read here is on your screen, called Elderhood, and I highly recommend it. It was published in 2019 by geriatrician Louise Arnson, MD, and she wrote this book to try to help the society in a whole, but also medicine, in the way they think about geriatrics, or the way we think about aging. She takes the stance that we should think of geriatrics or people that are going, the older people that are in their elder years, or elderhood, as she calls it, that we should think about them much like we think about individuals going through childhood or adulthood, that there's not just one type of person and there's not just one stage. Just like a child will go through many stages, and then those stages are defined and understood medically, emotionally, physically. We should also have that same attitude with our elders. And unfortunately, that's never really been done from a medical standpoint. So I'm hoping tonight that I can give you some ideas how to think in these terms of elderhood, and what stages we could create for our elder patients, and then use that to help guide our treatment. I often hear doctors say, or dentists say, age is just a number. And it is. I mean, we all know people who are in their elder years and are very active and fit, but we also know patients or have friends or family that are not. And we need to somehow create categories and help to treat patients where they are, not a one size fits all. So I'm hoping tonight we can expound on that, and I can give you some ideas for your own practice on how to categorize patients and help in treatment decisions. So one of the things that we need to realize is that the lifespans of our patients increasing greatly. The average age of death in the United States is about 79 years old, but it's a little misleading, because if a female, as you can see, makes it to age 65, she will live till approximately 85.3. And if that female makes it to age 80, that average age of death then goes to age 90. So although the overall death age may be lowering some in the United States, when we're looking at our seniors who made it to their senior years, they are lasting longer and longer. And and you can see the male equivalent underneath. So when you see a man that comes in your office at age 80, there's the likelihood of him living to 88.5 is high. This is like the average would be the average death age for that person. So I find it a challenge in my practice. I have patients that come in they're in their early 70s and they say something like, well, I don't know how many years I have when I start discussing treatment with them. And I have to remind them of the statistic that we've got, the statistics show that they are going to be living longer. And the other thing that I found that's happening in my practice, which I don't think dentists in previous generations saw, is those patients are coming in with dentition or full dentition, some of them, and a lot of them, most of their dentition, if not all of their dentition. So I think when I think about the generations, and I'll show you examples in my own family of how that's will be an impact on us moving forward as a profession. So medicine has increased patient longevity, and we as dentists and in dentistry, we need to figure out how we're going to respond to that. This is a picture of myself, and this is my grandmother on my mom's side. And this is a picture that was taken in March of 2020 on her 100th birthday. So I have some long life genes in my family, and my grandmother, which we affectionately call Gigi, is one of the reasons that I'm passionate about geriatric dentistry. So you can imagine that was March of 2020, which was, right when the world was starting to shut down. And we had planned a large gathering of people for her birthday, and we were unable to do that with COVID. So we were planning on going to a casino because that's what she loves to do. And we ended up creating a casino in our house to try to have fun with her. But my grandmother is, like I said, part of my inspiration. And she reminds me every day that people are living much longer. And she is still with us. We're in this March, we will be celebrating her 102nd birthday. So we're very excited about that. So to talk about how we're going to handle patients moving forward, we have to try to create some definitions. And frailty is a word that is used in medicine quite a bit to discuss the conditions of our elder patients. The problem is frailty is not very well defined in the medical literature. This is basically what I have before you is the sort of consensus of this definition medically right now, that it's a medical syndrome that combines aging with the outcomes of multiple long-term conditions. The main thing you need to know is that it includes the loss of fitness, and it also includes a loss of reserve for the patient and also a loss of resilience, meaning they will not respond or bounce back from treatment like they would before. Basically, the 5 traits that are agreed upon in the definition of frailty would be a patient that lost weight, they've lost strength, they've reduced their physical activity, and they've reduced the speed of their gait, and they self-report exhaustion. So for me in my practice, of these 5 physical traits, I use reduced speed of gait quite a bit to assess a patient. As the patient's coming into the office and back into the treatment area, we can see, what's happened with the speed of their gait. Not just are they using something to aid in their walking, but like how sure are they walking slower. So everyone in my office is trained to notice that, so that we can use that in helping to assess the patient. So basically, in my office, we categorize patients into 3 categories. And these are the names that I've created for these patients, because there's not any consensus out there on how to do this, even in the medical literature. So I created the category senior, which would be a patient who is over the age of 65, but is not frail or fragile at all, would be considered a robust patient. then they would have robust health regardless of their age. And then in our everyday language at the office, we use the term super senior. In my mind, this is a patient that would be considered pre-frail or pre-fragile, and they would have a reduced gait, like slower gait, but not be maybe using a walker, but not all the way into a wheelchair. And what we're told by the data is that about 45% of seniors that are not in a nursing home could be considered pre-frail or pre-fragile. And then the fragile seniors are frail. So those are the ones that might be in a wheelchair already or bedridden, and up to 16% of non-nursing home older adults could be considered fragile or frail. So you can see that a lot of there is quite a community living independently out there that would be possibly coming into your office that are like super senior status, pre-frail, or fragile. So I'm just going to kind of go a little deeper into each category so you can get a better idea of how we use it in our office and how we would categorize patients. So this is a picture of also my family. That's my father and my son, and they're getting ready to go fishing. My son's acting kind of goofy. My father luckily lives close to me. We get to see him often. He lives with my mother as well. And my father is in his early 70s. So he would be considered a senior. He's right at the beginning of that baby boom, the baby boomers. And I would consider him robust in health. So although he's had some medical challenges throughout his life, he still ticks off these boxes over here. He lives on his own independently. These patients that are seniors some of them are still working. Some of them are partially retired or fully retired. They still like to drive. They still travel. Obviously with COVID, maybe a little less, but they're still up for traveling. They're living their lives to the fullest. Usually they have a spouse that's also doing well. If they are married, they don't have any issues with dexterity. Their medical issues can be anywhere from mild to severe, depending, but they're usually under the care of a doctor and controlled and not limiting their mobility. Their medications are anywhere from 0 to 10 medications. And a lot of times these seniors I find are, you might have to probe a little bit more to get information about their medical history from them. A lot of times they feel like they're doing great. They're moving and grooving and very active. So they sometimes downplay any medical conditions they may have. But all in all, these are, active seniors that want to remain active. The super senior or pre-frail category, and I use the term super senior because I actually interact with this population quite a bit. And if you talked to a person and you told them they are pre-frail or pre-fragile, it would not go over very well. So I created the term super senior. It seems to be more palatable to the patients because to me, they're just super. I mean, they've lived like my grandmother there. You can see this is actually a picture of her at a casino prior to COVID. They've had a lot, they've experienced a lot in their lives. So a lot of the super seniors are still living independently or maybe living in an independent living community. They usually are fully retired at this point. They may still be driving, usually confined distances or not very far from where they live. Like my grandmother, she's not driving now, but 5 years ago she was, and she didn't get on the highway, that kind of stuff. There's usually little to no traveling, especially by air. These patients are either taking care of a spouse, or a lot of them have lost their spouse. Their dexterity does start to become an issue at this stage. So sometimes we'll see they're unable to clean their mouth appropriately due to their dexterity issues. They will have moderate to severe medical issues normally. And of course, these are all normals or averages. Some may have more or less. Most of them are taking anywhere from 5 to 10 medications. And these patients tend to talk a lot about their doctor's visits. They have a lot of doctor's visits, and they have to fit your visit in between all the rest of the other doctor visits. And they do tend to move more gingerly with a cane, sometimes not, but their gait is slowing down. Finally, we get to those fragile seniors or frail seniors. Most of these patients are living in an assisted living or nursing home. They are usually unable to work and unable to leave the facility on their own. So they're going to have a caregiver of some kind outside, usually, of the assisted living or nursing home. Adult children are usually the ones that are taking care of them. A lot of them are unable to perform adequate oral hygiene on themselves, or need help maybe remembering to do the oral hygiene. They usually have severe medical issues. We'll be taking anywhere from 5 to 10 medications. Dental appointments sometimes have to be cleared by their doctor, and they are moving very slowly, wheelchair bound, or not at all moving. So as you can see, that's how I divide out the group. So the elder population, because somehow we have to use that to make treatment decisions. So this is the basics of my treatment decisions. I say if they're a senior, then treatment is a go. If they're a super senior, your treatment is going to be go slow. And if they're a fragile senior, your treatment is going to be as little as possible, which would, in my book, be a no-go or just palliative care for that patient. So we're going to talk about each category again as it comes to treatment. And we'll start with the fragile seniors because we're going to spend the least amount of time on them. You do want to treat them with caution. You want to control pain and infection. In my office, that's pretty much all we're doing. You have to remember their reserve for recovery is lost. So, a lot of treatment, you can't do as much treatment at one time because they just don't recover well. And so we try to do as little as possible for these patients to keep their pain under control and infection under control. We try to keep the appointments short. A lot of times we reduce anesthetics to just try to be careful with their medical conditions. Some of these patients will have to be treated at home or by a traveling dentist in wherever they're living. And I think we do not have enough of people doing that right now to handle the fragile seniors that will be coming in the years. A lot of these patients I don't see in my office, or I only see them, as needed sporadically in my office. They're not on a continuing care basis. The super seniors I usually treat with care. One of the problems that we run into with this population is extreme xerostomia. And this usually is due to what is called polypharmacy. So polypharmacy also is not very well defined by the medical profession, but basically it's taking a lot of medication. So we'll go into that a little bit more on the next slide. For these patients, the super seniors, the function is of most importance. Most of them, when they get to this stage, they definitely want to be able to still chew and eat and have that be pain-free. Some of my patients still do want improved aesthetics. So if the patient desires it, that's something that we do. I do at this stage start to recommend removable. If the patient has many teeth that are missing, then I would recommend doing removable, because doing something like an implant in a patient in this area can be challenging depending on how much reserve that they have. Although I will tell you, we do them sometimes depending on each patient. You usually can reduce the anesthetics that you use on these patients. The pain is not is not there like it is for younger patients. And I recommend, if surgery is needed for these patients, to remove all teeth at once. Their recovery is a challenge. So where you might on another patient remove teeth on one side and then come back for the other, getting them to come back is hard because it's a very challenging recovery for them, depending on how many teeth have to be removed. So let's talk about polypharmacy. Polypharmacy, the definition that's mostly agreed upon by the medical profession is this one, that it's the use of several, usually 5 or more medications on a daily basis, with the possibility that all of the medications may not be clinically necessary. So in most of the medical literature, they do agree that 5 or more medications, it meets the cutoff for polypharmacy. And some definitions include over-the-counter medications in that as well, that a patient is taking regularly or daily. And if you're treating patients over 65, you understand that 5 or more is very easy to get to. So basically 5 or more medications on a daily basis, prescription or over the counter. Or if you're taking 2 medications or more to treat the same condition, if you're taking a medication, if the patient is taking a medication that is used to treat the effects or side effects of another medication, this is something that we're seeing a lot. You take this medication for one thing and it causes this. Now I'm going to take another medication to help with the side effect. So that would be considered polypharmacy. If they're taking 2 medications that compete with each other, or if there is a prescription cascade, which is defined as when an adverse drug reaction is now seen as a new disease and a new medication is added to it. So that's not always recognized that that's just an adverse reaction from the medication. And sometimes this side effect is treated as a new disease. Polypharmacy is something that affects the dental profession greatly, and it is very common. If you can see here that if you're over the age of 65, 44% of people over the age of 65 are taking 5 or more medications. So basically, that's almost half of my population. My patients the average age of my patients is over the age of 65. So over half of my patients have polypharmacy, are taking more than 5 medications. And you can see 11% take 10 or more medications. So that's quite a bit of our population over age 65 that is impacted. You can also see that adverse reactions are very common. So if a patient is taking 5 or more medications, there's a 50% chance that that patient will be having an adverse reaction between 2 medications. If the patient is taking 20 or more medications, there's a 100% chance that there will be adverse reactions. So maybe one medication is fighting against another in its action. The thing that I think is most interesting is that the polypharmacy mostly occurs with elderly that are living at home. Once the patient becomes moved into an assisted living or a nursing home, they tend at that time to have one physician that is overseeing all of their medications. And then at that point, the polypharmacy is decreased. And a lot of patients are moved off of medications or found better ones that are not competing. But the population that we are going to see at our offices is not that population. We are going to see patients mostly who are living at home or living independently. And those patients are the ones that are at the increased risk of having polypharmacy and having medications from multiple specialists all being prescribed without someone overseeing all of them. So polypharmacy creates extreme xerostomia, like I was saying, and extreme xerostomia creates extreme risk for caries. It creates increased periodontal risk. It creates inflamed and sensitive oral tissues and reduces the natural debris removal from the mouth. So I see this in almost all of my patients, and it's very challenging. They complain, and they have a lot of decay, a lot of root decay that is challenging to take care of. So let's talk about treating the seniors. So we talked about treating the fragile patients. We talked about the super seniors. The seniors is where I think we can have the greatest impact. I treat the senior population proactively. I am very careful to evaluate their occlusion and to address that. Longevity of restorations is of utmost importance, because we understand that these patients are probably going to be living at minimum another 20 years. We do improve cosmetics a lot of times along with occlusion. If the patient is missing teeth or if teeth have to be removed, I highly recommend implants, because I know that they're going to give them better function, and there'll be no risk of decay around those restorations. So to me, that is this population, by being very proactive in our treatment, we can set them up so that when they move into their super senior years and their fragile years, they're having to have very little dental treatment done. And that would be the ideal situation for those patients, because it becomes harder and harder to do the work. So I'm going to go over a case with you really quickly where I did this. So a lot of times I hear from dentists, oh, the patients are too old, or the patient says they're too old and they don't want to do proactive work. And that was what I thought for many years as well. Like, I would have this patient come in, Sandra, we were seeing her on a continuing care basis for many years. And at the time we started treatment for her, she was 75 years old with a history of asthma, previous breast cancer treatment, which was successful and had not returned, and a penicillin allergy. So she was what I would call senior. She's in relatively good health, takes very few medications just for the asthma and some allergy medications. And when I think about her, 75, okay, we've got a long time here left to go. So she came in, and at the day of her recare appointment, she came in, she was complaining that filling had come out of tooth number 9. She had a distal lingual composite on tooth number 9. So as you can see from her bite, like it's probably her occlusion. We started having a discussion there about her bite. She had previous orthodontics when she was a teenager, and they removed teeth on her. And I began talking to her about the wear on her front teeth, because I in my mind, I'm thinking, I put this filling back in, it's going to come back out eventually because of the wear that's happening to her front teeth. And that's just going to get worse over the next 20 years. And if I think 5, 10, 15 years down the road, she's not going to be able to undergo treatment very easily at that point. So I discussed with her bite, and she told me, well, I was always told I needed jaw surgery, and I don't want to have jaw surgery. And you can tell by how candid she is, her ramus is smaller on one side than the other. This is not a necessarily easy case, but I did get to send her to a colleague that works with non-surgical treatment. He uses the multi-loop edgewise archwire technique, my colleague, Dr. Chang, and she was very excited. I mean, she was happy there was something she could do to help to preserve her teeth for the long run, because she understood after we discussed this that, you know, this isn't like she's just going to be chewing on these teeth for 5 more years. I mean, she expects to live a very long life. And I don't want her to run into a situation where we're having to fix things or do major treatment or extractions on her when she's in her 80s or even 90s. So I hear a lot that, dentists think that patients will not move forward with treatment, and some do not, of course. But I think by talking to them and I said to Sandra, look, you are not a super senior yet. I treat patients, seniors, super seniors, and you're not that yet, because a lot of times they think they are. And I'm like, you're not it. But my goal is when you are that we're doing very little work. And she was on board. What do I have to do to make that happen? So we did the orthodontics. As you can see, she finished the orthodontic treatment in May of 2020. And I think that Dr. Chang did a great result. We are now currently in the process. She did have to have number 30 removed. So we're currently in the process of restoring her posterior teeth so that we can have an ideal bite for her that will last her hopefully to the end of her life, and she won't need to have continued treatment. So this is the type of case that I think is out there and available, and we just have to speak to these seniors in a way that gets them to understand, like, yes, we need to do work now proactively so that by the time you're 85, all you're doing is coming in and getting your teeth cleaned, and we're taking care of you. And they realize, because most of them have seen their own parents go through the stages and become a super senior and then become fragile, that it becomes harder and harder to have any kind of medical work done. And more of them are willing to move into treatment for all kinds of things. So in my practice, the general rules and my practice for treating a senior, or what I do daily with my senior patients, is that we evaluate all root canals annually and try to evaluate the prognosis for those. And if I see a root canal that's already, that's been in the mouth for a long time and starting to break down or have problems, then I will proactively recommend that they consider having it removed and having an implant placed. We are assessing their periodontal condition as fair, and we're treating fair or poor areas proactively. It's saying the same thing. We know that this is the best time to move forward with treatment because it's just going to get harder. I try during this time to establish the importance of good oral hygiene techniques. So as patients move into their super senior years and more fragile years, it is harder for them to change their habits. So I try to get my seniors to become proficient using an electronic toothbrush and maybe using a water pick, even if it's not something that they necessarily need at that moment. I know that in the future, having an electric toothbrush is a much better way for them to clean when their dexterity starts to be reduced. And if I can get them in the habit of using it as a senior, then they will be very comfortable with it. Introducing that to them, as a super senior or someone that's in a fragile state can be very challenging. I like to establish with the patient the importance of more frequent recall schedules, especially if they have a lot of restorative work, just to get them in the habit of it. So as they experience problems with their health, they are in optimal dental health before they have problems, because we know they're going to be having other healthcare problems that may take them away from our office for periods of time if they're hospitalized or get sick. I started to use silver diamine fluoride. I'm not sure how many people have started using that or have heard of it. I've been using silver diamine fluoride with my senior population for probably about 5 years now, 4 or 5 years, and it's an excellent tool to use preventatively. And any of my patients that are in their senior years or super senior years that have extensive restorative work, we place the silver diamine around the restoration margins to try to help prevent decay and to strengthen those margins, because that is what happens when as they get as that polypharmacy sets into the patient, the mouth becomes extremely dry, and then they start getting root decay. And once that root decay has started, it is a challenge to get it to stop. So that is basically, we use it on a daily basis. And right now, the schedule we're using is to apply the silver diamine fluoride every 6 months as they come in. There's not a ton of studies on seniors with silver diamine. There's some, not near as many as in pediatrics. So a lot of the data on silver diamine fluoride comes out of pediatric studies, but it is working very well for me and my patients. And like I said, I'm using it proactively, and I'm also using it. So before there's any decay, we're using it. And then we're also using it as a treatment if someone comes in with decay. I discuss with my seniors very clearly about the disruption to quality of life if they lost teeth. So we have discussions about that on a regular basis with our patients as they're coming in, just to try to impart with them that, like, hey, we can proactively do work now to help you maintain the quality of life that you want. Something that I tell almost all my patients, that chewing is very important and eating is important. That was something I learned from my grandmother. I've watched her over the last, 20 years. 20 years ago, she was dancing regularly at foxtrots and was driving herself to the casino, which is about an hour from here. And over the last 20 years, that's all diminished. She's not able to drive anymore. She's unable to go. So it's hard for her to go to dances. She can't dance. Her dexterity with that, her mobility has decreased. She can't get to the casino unless someone takes her. So it's a lot less than it normally was. But what I can tell you is she is still eating every day and she still enjoys food. So I really think that we need to clearly state that to our patients, and the seniors are receptive to it. When you talk to them in those terms and say, whatever it is you love to do right now, fishing or driving a car or dancing, going to movies, there will come hiking, whatever it is, there will probably come a time when you're not able to do that near as much as you can right now. And at that point, the act of eating becomes more and more important. You will meet with your friends for coffee, or you'll meet with your friends for lunch, and that will be a source of enjoyment for you. So, and that's our goal, is to continue that throughout their lives. And I'm kind of frank with them. I tell them, I don't know about you, but my plan is to eat a steak as my final meal with some butter on it, medium rare. So, and that, gets a laugh out of them usually. And they understand that where I'm coming from and why it's important to me. I do also on a regular basis talk about the fact that all dental work will need to be replaced at some point. Nothing that we do or anyone has done before me is going to last forever, especially when we are living so much longer. The dentists before me did great work, and they've created a generation of baby boomers who have mostly kept their teeth, and it's amazing. And but it's not going to last forever. We are going to have to do work. And I try to establish a proactive treatment. I try to tell the patients proactive treatment is always preferred over reactive treatment. So we're constantly looking at those large fillings, what needs to be done to proactively create an environment that will hold up for the long term for those patients. Finally, I just wanted to say that 10,000 people are actually turning 65 years old every day in the United States. So we have a lot of people that are coming into the senior pipeline. And one of the most amazing things that I read that I just added to my slides is that those people, those seniors, super seniors, they control 2/3 of the disposable income in the United States. So these patients, they have disposable income, which is what we use, right, to get dentistry done, because we know that insurance doesn't really cover it. So I think there's a lot of people out there who are more than happy to create a better quality of life for themselves if we are more proactive in treating those seniors, so that they don't, when they become super seniors or fragile, we're not doing near as much dentistry on them as we might have to. So that's all I have for this evening. I hope this was informative, and we can open it up to any questions that you might have.
Thank you, Dr. Skaggs. We do have a couple questions.
Great.
The first one is from Rita, and she asks, would you comment on treating seniors for craniofacial pain? Thank you.
Yes. So I think that, that can be a little challenging. Sometimes there's definitely some studies out there that show there is more pain in general in seniors, but I do find in my population, those are the I refer quite a few patients for craniofacial pain, and a lot of them have just lived with the discomfort for a very long time, thinking that there's nothing that they can do. So probably by the time they get to you to be treated for craniofacial pain, this is a very long-term chronic condition that has not been handled. So I know that can make it much more challenging. So I do think that, we have to try to educate general practitioners that these patients need to be referred for help, and that there are more options available than there ever have been for that treatment. It does get challenging because they are on a lot of medications. So you have to, if you're using medications for treatment, then that can be challenging, navigating the polypharmacy that they've already brought to you.
How has COVID-19 adjusted the way your practice works with the elderly?
Yes. So this is a great question. So yeah, I was really concerned when we came back, or we started back after our shutdown, on how it was going to impact our practice, because our patients are elderly. So first of all, we are taking every precaution we can above and beyond to protect our patients. I can tell you that they were very slow coming into the practice. A lot of them held off for a long time. So there are patients I'm just now seeing that I haven't seen in 2 years. Also, I can also tell you quite a few of them, because I have quite a population of patients that live in independent living communities around. So these are large apartment complexes that, cater to seniors. And all of those communities were very, very tight in their, they locked their patients in, basically. They didn't want any spread within their community. So they were very proactive in keeping the residents in their rooms, not letting them congregate with each other, not letting them interact with each other. And the seniors did not like it. I got a lot of patients that would come in complaining, saying, we had to come here because they will only let us leave for medical appointments. And then I would say, and then they would have to quarantine for 2 weeks after their medical appointment. So I really got a sense of how the patients didn't like it. I mean, these patients were not happy that they were not able to interact with their friends. I mean, it really hit the senior community hard. They were basically staying in their apartment, having to stay in their apartment and not even talk to their neighbor next door face to face. And it was challenging. So overall, I feel like of course, we did lose patients to COVID-19, which is very sad. I'm sure we all have, but all in all, they're doing better now. They're more open and letting them move around and come to visits. I had quite a few people that were like, doctor, can I come back next week so you can check my crown? Because they wanted another opportunity to leave the facility where they were living. And then the adult children would take them out to lunch or something after my appointment because they were so lonely that they would, I mean, it's awful when you're so lonely, you come to the dentist to see people, but that's what they were doing. So I'm glad that it's not quite that bad. I'm really hoping with this surge that it won't go back to that for them. So.
Sharad asks, would you do full rehab on old patients with severe attrition and TMD?
So I think that is where you have to look at their status. Like, are they a senior or are they a super senior? For me, once you hit into that super senior category, I feel like they're starting already to decline. But I think the seniors, even independent of age, if they are in, they're still mobile, they're still whatever, then I feel like that would be appropriate for that patient. Obviously, they'd have to agree, and you would have to. I would employ other people to help me with that, managing the TMD and other things. But I think that we really need to look at that. We can't just say, oh, they're over 65, we're not going to do a full rehab, because there's a lot of those patients out there that have a lot of attrition, as you know, and I think doing it, waiting, not doing it, and now they're in their super senior status and teeth are breaking off at the gum line, or they're fracturing roots down and teeth are having to be extracted, is also not a good situation. So for me and for my practice, we've sort of moved toward that, using that senior, super senior distinction as to helping us treatment plan.
Have you had success with any products for patients with extreme xerostomia due to prescriptions?
Okay, so I have a list of things that I recommend for the patient, and I'll kind of go over them really quickly. But the short answer is there's really not a silver bullet of products. I definitely get the patient on an electric toothbrush right away to help with their cleaning. We talk about diet and drinking more water because most of them are extremely dehydrated. Also, I talk to them about a humidifier in their bedroom because most of them are mouth breathing and it's very dry. Then the products, you've got your basic over-the-counter products like your rinses, your Bioteens. There's a couple of others out there. I find if they're extreme xerostomic, a rinse doesn't help. They need a gel, like a thicker gel formula. And then I've also prescribed several of the newer medications like Saliva Max and I can't think of it, or Nutrisal. Those are the two that are a powder. You mix it with a water. It's supposed to create a better ionic balance in the mouth, not necessarily moisturize. They're putting it out there. So those are two prescriptions and they work well, I find, for patients who have maybe like burning in their mouth from it being so dry, but it's not overly helpful. I mean, you kind of almost have to try a little bit. Yes, and you're right. Dr. Silver, Oral Science does make some good xylitol products. But what I find is it's like, you kind of have to try several and then the patient picks the one that's the best for them. I haven't found one that's like everybody likes it. So it can be a bit of a challenge with the patient. And of course, even with the product, it's not really replacing the saliva, right? It's kind of just trying to make it as comfortable as we can for the patient. I do find that patients with removable prosthesis have a lot more problems with sore spots and stuff like that when their mouth is really dry. If you email me too, I can send you the list of what I have for dentists to look through. But like I said, I wish there was a silver bullet. Yes, I do. Dr. Silver, I would 100% agree with you. I believe there has been an uptick in dry mouth with mask wearing. That for me, that's what I'm seeing. I'm experiencing it myself. I think people have a tendency to mouth breathe more in the mask than they would on a regular without the mask on. So that's what I'm attributing it to, but I don't really know if we know. But also the other thing, besides the humidifier in the room, I do talk to my CPAP patients and make sure that they are using the humidifier feature in their CPAP, because many are not, and that's just drying everything out more.
Well, thank you, Dr. Skaggs, for that. It was a wonderful presentation. Thank you, Dr. Skaggs, for all that wonderful information.
Thank you very much. I hope you'll have a good evening.